So my topic is covering the intraoperative complications that could possibly arise during a hardware removal procedure. As easy as it sounds to remove a couple of plates and screws, there are many things that could possibly cause failure. Regardless of how minimal the procedure may seem, proper planning and preparedness are integral to the success of the removal. It is really important to make sure that you hope for the best but expect for the worst. And by this, I mean to have all the materials that you could possibly have or need in order to do the procedure. Expect that the surgery is going to need all the materials and maybe even more. The main question is, when do you actually have to remove the implant? So there are a bunch of reasons for why you might need to remove it. If the implant breaks or moves, it is usually necessary to remove it. Also, if there's an infection in the fracture, it used to be mandatory to remove the fracture, but more recent literature states that healing can still be accomplished with the hardware intact. Many patients believe that regardless of what the hardware is, that it's causing them pain. And when in fact it may actually be something else that's causing them this pain, like post-op arthritis or inflammation or a slew of other things. Patients will get it in their mind and be certain that the plate needs to come out. But if you, as the physician, think that it doesn't need to come out, then it's not necessary to put the patient through the risk of surgery. So, as I stated earlier, the development of a deep wound infection in the presence of hardware after open reduction and internal fixation presents a clinical dilemma, and there is not a definitive answer if the hardware needs to come out or not. If there's an osseous union with the maintenance of the hardware after the development of postoperative infection within 6 weeks, after internal fixation of a fracture, then it usually is not going to have good results, is what the article is saying. So on the next slide, in the article, Maintenance of Hardware After Early Postoperative Infection Following Internal Fixation, written by Burks, he sets out to test the healing while leaving the fixator in with the presence of infection. The article is a retrospective article, and it looked at patients from a level 1 trauma facility based on their billing and trauma registries. Some of the patients had infections with positive intraoperative cultures that had developed 6 weeks after the internal fixation. They specifically looked at the patients that did not have their hardware removed in the presence of this infection, and the success and failure was evaluated from this. The results stated that 71% of the patients that had a fracture with union with correct culture-specific antibiotic treatment and infection suppression, so if they got the right antibiotics, then they usually had a higher chance of healing. There were also other variables that had to be considered with the failure rate, such as smoking, infection with Pseudomonas, and other involvement of other bones and other areas. But the conclusion of the study states that a deep infection after internal fixation of a fracture can be treated successfully with operative debridement, antibiotic suppression, and retention of the hardware until fracture union occurs. So these results may be improved by patient selection, and choosing the patients that have less risk factors and more treatable bacterial infections. So the actual process of removing the implant itself is complex. This is especially true of the deep implants that have been in place for a long period of time. Fractures have been known to occur soon after the surgery as the weakened bone collapse into the drill hole spaces, particularly in the weight-bearing bones of the leg or the hip. The removal of an implant should never be taken lightly. As with any kind of orthopedic surgery or podiatric surgery or anything, there are risks of infection, nerve injury, and a reaction to anesthesia. So the removal of an implant may weaken the bone or fail to alleviate the pain in general, which would not leave for a happy patient. When actually removing the bone, the hard part is that if the plate has been in place for a long period of time, then there may be an overgrowth of bone. Titanium screws can become encased or stripped during the process of the initial open reduction internal fixation, and the surgeon doesn't expect for them to ever have to take the plate out, so they don't care that the screw is stripped at that point in time. So many screws will end up with damaged heads, and this increases the odds of a complication during removal. And if you're unaware that a screw has previously been stripped and you're attempting to remove the screw with only the tools that you brought in for the surgery, then you may need to wait for someone to go running grabbing new tools, or the tools might not even be in that hospital. So you need to make sure you're prepared. So we're going to get into some of the specific tools that you should have in the surgical room before you start the procedure later on in the presentation. Some surgeon will try to make it work with the tools that they have in the room, and this has the potential to cause further complications and can make the situation much, much worse than it was when you started with the patient. So the old saying in America that is that if it isn't broke, then don't try and fix it. And this definitely goes for the hardware in the leg. If the hardware is not causing issues, then just don't remove it and leave it in. So some people like to prophylactically remove the hardware as soon as the bone is healed. But as we stated earlier, this will open up a lot more complications from the surgery and it could cause refracture. And there's a lot of hardware removal procedures that used to be done in children, but now the trend is moving towards leaving these implants in. So there's an area of avascularity around the bone where the implant that needs to be considered when removing the implant. This could lead to an area of necrosis. There are several factors with the screw and implants that could lead to a weaker bone also. The screw and plate can also be providing stress loading, so when the implant is removed, this area can be prone to refracture. Also, the area can be weakened by the removal of the screws due to the holes that are left behind in the cortical margin of the bone. A single screw hole can decrease the compressive load of cancellous bone 20% or the torsional stability of diaphyseal bone 50%. Patients need to be aware of these risks and avoid impact or torsional activity until the strength has been returned. A model of a single screw hole showed torsional strength returns in approximately 4 weeks, but radiographic findings in an adult show it does not return to a near normal limit until 18 weeks. The data on the return of normal strength in humans and hardware removal is not known, but protecting long bones after hardware removal for 2 to 3 months is reasonable. So hardware removal for fixation across joints is more controversial. So historically, syndesmotic screws and screws across the midfoot joints were often removed, but there are now mixed reviews on whether you should remove these or not. So there are certainly case series on implants being left in place with no known ill effects. The key to this is to plan out the treatment as best as you can, and you need to get a good CT or MRI that will show you the extent of the bone healing and show you if there's a union forming between the two shards of bone. So if there's infection, a bone scan can be utilized to differentiate between a stress reaction and infection. You have to make sure that there's no foreign body that could possibly be causing this infection. If the infection presents less than 6 weeks from surgery, there's a high chance that the bone is not healed yet, and removing the hardware will cause a lot of instability. So when removing the screw or the plate, in some cases there must be a lot of force used in order to get the screw loose. You can use a mallet in order to tap on the screw to loosen the head up. And when working on it, you may realize that one of the screws is stripped or broken, and this is where the specific tools that come in that you need to have at your disposal in order to make sure that you're prepared for this procedure. So there are broken screw extractor tips and stripped head and C-screw extractor tips. Some other tools that you can utilize are the T-handle ratcheting screw remover for quick and efficient removal. Sometimes the screw will be far away from the incision site and the extractor handle may be used to reach them. So when choosing the size for the extractor for broken screws, it's imperative that the right size is chosen. If the extractor is too big, then excessive bone removal will occur and this will end up weakening the bone even more. So there's also specific tools that can be used to remove the cannulated screws that are stripped and broken. They're designed for efficient screw removal and minimal bone loss. Some of the problems that are unique to locking plate removal include cold welding of the screw heads and into the plates, or cross-threading between the screw threads on the screw heads and in the plate hole. These situations may arise as a result of the use of improper techniques during insertion, and there may be damage to the recess on the screw heads, which is stripping, or the screw head may be broken. So cold welding may occur on titanium implants between the screw head and the hole plate, especially if torque limiting screwdriver was not used for tightening of the screw. So cross-threading between the screws on the screw head and the thread of plates may occur if the direction of insertion of the screw was not with the direction of the hole in the plate, or if the insertion sleeve was not used. So how can you prevent these complications? So you just need to prepare for anything basically, and make sure you can plan out the surgery as best as you can. Just have the tools readily available. And if you can do this and you can prepare for the worst, then you're going to limit your complications and the surgery will flow a lot smoother.